zipping through the first few slides. Financial relationships to disclose. And I won't be discussing off-label or investigational use. The protocols we're going to be discussing today are the lip and oral cavity, larynx, nasal cavity, and paranasal sinus, major salivary gland protocols. And these are available at www.cap.org under the References, Resources, and Publications tab. And these protocols were updated in October 2013. The objectives of my presentation are to review the most recent versions of the CAP protocols for head and neck cancer. I'm going to use the oral cavity and lip protocol as the prototype. I'll be sort of diverting into the discussion of the others as I go. And towards the end, I'll highlight the important and unique components of protocols at the other sites and highlight the changes from the prior checklist versions. I'm going to discuss common problems relating to the application of the protocol requirements and discuss my approach to resolving them. I don't think there's any standard approach to resolving some of these issues, and I'd certainly be happy for the input of others if you have suggestions or comments that might differ from my own. So tumors are covered in these protocols, and I've divided them by carcinomas. Of course, the majority being squamous cell carcinomas in sight, but all carcinomas are covered by these major protocols. Melanoma, covered in the lip and oral cavity protocol, the larynx protocol, the cavity and paranasal sinus protocol, and the Pharynx protocol. The major salivary gland protocol doesn't cover melanomas. Most melanomas that I see in the salivary glands are obviously metastatic melanomas to interparotid lymph nodes, not primary melanomas. Sarcomas and lymphomas are not covered by these protocols. And neuroectodermal tumors such as olfactory neuroblastoma, viewing sarcoma of the nasal cavity and paranasal sinuses are covered by the protocols. Salivary gland carcinomas are covered by the site-specific protocols depending on where it arise. So, head cancer specimens, there's a peculiar, not unique, I don't think, but certainly very challenging series of problems that can arise when you're trying to apply the protocol to these types of specimens. It's difficult to apply the PT staging rules. The regional anatomy can be quite complex. The organs are close together, often considerably altered by the tumor. Often receive multiple sites and sometimes multiple or portions of organs in one specimen. And sometimes these can be very poorly oriented and be difficult to identify grossly. And the other issue that commonly arises is the necessity to incorporate clinical information in the stage at these sites. Just with respect to the specimen assessment and reporting, it's not uncommon to receive multiple specimens with these cases. What you have is a main specimen, usually a resection specimen with or without a neck dissection, and have multiple margins, an entire mucosal margin around the periphery of the specimen. May not have margin revisions beyond that. So it creates challenges as how to report that, and I'll just discuss my approach. Sometimes you get piecemeal resections, so you get specimens that come out in more than one piece. It's very difficult to know where the true margins are. Specimens can be fragmented, and one example of that would be a maxillectomy. All specimens, because the bone around the nasal cavity and the sinuses is so fragile, they often end up being quite fragmented. we've started receiving a lot of laser resections, for early stage cancer of the glottis, but more recently as well, laser resections for oropharyngeal tumors as well, the non-keratinizing type squamous cell carcinoma. To properly report these specimens, you really have to cooperate with your surgeons and try and get them to provide you with as much information as you can when you receive the specimen. These are a couple of typical specimens that you might see. These are both hemiglolectomy specimens. And this is a very typical type of specimen, and usually what happens is we will receive the specimen. We'll also receive margins around the entire periphery of the mucosa, as well as usually selected deep margins as well. So what I would do is I would put through real sections of the anterior margin and the posterior, or sort of close to the base of tongue margin, and then serial cross sections through the mid portion of the specimen. To report these margins in a minute. This is a more challenging specimen that I received the other day, and I think it really illustrates some of the problems that can arise. This is a oropharyngeal squamous cell carcinoma resection specimen sent by one of our ENT surgeons, and it actually came out in multiple pieces. So the tumor was submitted as superior portion of left tonsil, middle portion of left tonsil, inferior portion of left tonsil, and left base of tongue. And in fact, all these specimens, the superior, middle, and inferior, have squamous cell carcinoma in them. This is it, this firm whitish tissue here. So, without direction, we're not going to be able to reconstruct these specimens into the whole. And it's really of necessity, I think, in these cases, to rely on the mucosal margins that have been submitted separately, either for permanent sections or as a frozen section. I think it's possible to assess the deep margin. And we asked one of our surgeons to keep some ink in the operating room so that he can some black ink on the deep margin. As it's very difficult to know where the deep margin actually is, because you have a interface between two adjacent pieces of tissue that directly merges with the deep margin. Another problem that arises is that it's essentially impossible to accurately determine the distances from the mucosal margins in these circumstances. Here's a maxillectomy specimen. Again, margins can be a problem here. This is a hemimaxillectomy, a right hemimaxillectomy. This specimen was actually removed for sarcoma, even though we're not dealing with sarcoma in these CAP protocols. This was the specimen that I could find a picture of. But you see the tumor here that's proceeding into the right maxillary sinus and through the lateral wall of the nasal cavity. And this is a portion of the nasal septum here. So the superior aspect of this specimen, the actual mucosal margins around here are going to be very difficult to assess and are fragmented. So I think it's really, in these cases, you don't have a choice but to rely on the separately submitted frozen section or permanent margins, whatever they choose to submit. You have to rely on those as your mucosal margins. The other issue here is often with a sort of a posterior or base of skull margin, which in this case is positive. The surgeon has gone back and removed separate tissue from the base of the skull. So you have to report that separately. So what do I do then in a nutshell? Read the definition of synoptic reporting document put out by the CAP. It's that the synopsis can appear in the diagnosis section of the pathology report, at the report, or in a separate section. But all our data elements and responses must be listed together in one location. instances, you may actually have 12 or 15 specimens, just depending on the case, how many margins were taken, whether or not there was any necessity to revise margins. So my approach is that I apply the synoptic report to the main resection specimen. For instance, that might be a mandibulectomy and a neck dissection, and I would put that in the microscopic description section of my report. So mandibulectomy and neck dissection was specimen G and H, and there were specimens A through F, which were frozen sections. Put in my microscopic description G and H, mandibulectomy and neck dissection specimen, and report my synoptic in there. What I do is I list the diagnoses, every single one separately for each specimen, as they're submitted by the surgeons. I would include all the margins, or all the margin revisions, and I report which specimens were subjected to a frozen section versus which specimens were not. Sometimes we run into issues where you have an initial margin, such as first posterior margin. They'll have more tissue resection, permanent specimens, then you have a second revision, and can go on sometimes a couple of times. So I list all those diagnoses separately, but except in very rare circumstances, my synoptic report applies to what I would consider to be the main resection specimen. And I sit at rounds, and sometimes we decide that the margin is clear, and sometimes we don't. The issue, I think, is that with the more common, straightforward specimens, the margins, in my experience, are usually not too much of a problem. They're usually able to get those deep margins that create a problem, and the surgeon rarely will examine the entire area of the deep margin of a specimen. And so when they send samples for frozen section from the deep margin, they're submitting the entire deep margin. And so I think it's important to report on the main section specimen the relationship of your tumor to the deep margin as you have received it. There may be tissue beyond that resected for a further deep margin, or they may not. Very variable depending on the case. Just a couple of minor issues. The protocols is a mixture of centimeters and millimeters in terms of what measurement you use for reporting. And in these protocols, the specimen size, and size of a metastatic focus in the lymph node are all reported centimeters, and distance to a margin, the extracapsular extension from a lymph node, tumor thickness are all reported in millimeters. We'll start with the lip and oral cavity protocol, and there are several changes made versus the last version, the most notable being the following. The first one being inclusion of a category of large cell carcinoma neuroendocrine type, or poorly differentiated neuroendocrine carcinoma, in addition to small carcinoma among the neuroendocrine tumor category. Involved lymph node measurement. The size was changed from largest positive lymph node to largest metastatic focus in a lymph node. Added extracapsular extension, identified or not, and not an optional element. The optional elements are indicated by the little plus sign. As an optional element, the distance from the lymph node capsule. And in the protocol, they had a classification scheme for isolated tumor cells and lymph nodes, which has been deleted. Okay, so in the lip and oral cavity, just to go through the elements, first of all, the first element is the specimen type, or the specimen organs that were received, or portions of organs, and you have to select all that apply. And of course, in some of these sections from the oral cavity, it would include multiple sites within the oral cavity. Just go over briefly, because it's handy to know and it's handy for grading, to know the most typical numbering category for teeth. So the typical way for numbering teeth is to divide the jaw into quadrants, 1, 2, 3, and 4, with 1 being the right jaw, and then going around clockwise until you get to the lower right jaw. And the teeth, of which we have 32 in the adult mouth, are numbered from 1 to 8, with 1 being the central incisor and 8 being the third molar. That's helpful actually when you're grossing these specimens, to just give the teeth a number if they come with teeth. Oftentimes, if they have very poor dentition, they'll actually remove all the teeth before they do surgery. Just to clarify a couple of things with respect to specimen site in the oral cavity. I don't know where they got this picture of this person with absolutely beautiful dentition. Kind of a dentist dream, I think, or a dentist nightmare if the dentist ever wants to retire. But the terminology of the oral mucosa can be a little bit confusing. The maxillary and mandibular or gutter is this portion down here where the cheek meets the alveolar process of the mandible, or the cheek meets the alveolar process of the maxilla. The alveolar process really is the portion of bone that's sticking out above the soft tissues that is covered by mucosa. The jaw itself really starts here at this line of attachment. So the attached gingiva, as well as portions of gingiva that extend between the teeth, the interdental gingiva, and gingiva that's sort of more free around the crown of the tooth itself. This mucosa here, covering the lower portion of the alveolar process, is just called alveolar mucosa. Data element is the tissue received, whether it's received fresh or in formalin. The procedure, which you can read there, select all that apply. The skin integrity, again, does become an issue for some types of specimen, like the maxillectomy I gave, and like laser resection, which can come glottis, for instance, as an anterior partial glossomy and a posterior partial glossectomy section, posterior portion with margins around it. The specimen size, tumor site, these are just identical to the specimen sites that I listed above. The protocol, there's quite an extensive anatomical site explanation with diagrams that I won't go into. Tumor focality is given as a single focus or multifocal disease. It's uncommon to have multifocal tumors in the oral cavity and elsewhere in the upper air digestive tract because of the field effect that you get in the oral cavity. Size, I give the greatest dimension in my synoptic reports. An optional element to give additional dimensions. These are included in the gross description. Next element is the tumor thickness. So I routinely provide these for low-stage tumors. I think that tumor thickness is probably a more accurate term than tumor depth, because it's rare for tumors to be the tumor to be even with respect to the surrounding mucosa. Usually they're heaped up, or sometimes they're ulcerated. So the thickness is really a more accurate description of what you're measuring. As far as tumor description goes, they do list as an optional element multiple gross subtypes. Use these descriptors in the gross description. And sometimes I might put them in the diagnosis, but they're not typically included as part of our synoptic report. The microscopic extent of the tumor, that's an interesting category, and it's paired with another one later in the protocol called microscopic extent of the tumor. And I think that can be helpful, as the protocols will often not mention other anatomical areas specifically that might be involved by a tumor. So, for instance, you may have a carcinoma of the floor of the mouth that's sending through the floor of the mouth into the submandibular gland, or maybe even into the skin of the face. And in my reports, I typically try and marry the macroscopic and microscopic extent of the tumor by examining the specimen grossly and taking appropriate sections to try and demonstrate what I think I've seen grossly. So I try and marry macroscopic and microscopic extent of tumor, and would include that in my diagnostic section. And you could include it as a separate category here if you wish, or would include it, I think, in the specimen site involved in another category. But I don't specifically use this component of the protocol. So here's an example. This is obviously a laryngectomy specimen, not an oral specimen, but this is sort of mean. So we have a laryngectomy specimen with an ulcerated transglottic tumor. It's eroding through actually the false vocal cord and the true vocal cord. It's extending up here onto the gel surface of the epiglottis. And this tumor, you see, is eroding to the preepiglottic fat. The hyoid bone will be up here. This is the anterior portion of the thyroid cartilage. This is the anterior portion of the cricoid cartilage, which you can see is much, much thinner anteriorly than it is posteriorly. And the tumor is extending through this cricothyroid ligament and also eroding through the thyroid cartilage itself in the extralaryngeal soft tissue. This is the thyroid gland here. So you could use that macroscopic extent to talk about this preepiglottic space, extralaryngeal extension, perhaps some extension even down into the trachea. Thickness or depth, as I said, I prefer the term thickness. I think this is an important measurement at the Q2. Oral cancers that are thicker than 4 or at most 5 millimeters are typically treated with a selective neck dissection, even in an N0 neck. That would be a level 1 to 3 selective neck section. And try and measure it from the mucosal surface, exclusive of any keratin that you might find on the mucosal surface, to the point of invasion in millimeters. In years, I found actually that the group measurements, both pre and post fixation, and microscopic slide usually correlates fairly well. So you can see just examples of this type of measurement in endophytic tumors, ulcer tumors, and endophytic tumors. Next comes histologic type. And oral squamous cell carcinoma, you have conventional squamous cell carcinoma, as well as the various of squamous cell carcinoma. I'm going to go through them all, just mention a few of them. Papillary squamous cell carcinoma, not that common in the oral cavity, but you do see them sometimes. You can also see them in the pharynx, sometimes overlying non-keratinizing invasive squamous cell carcinoma, or pharynx. And these are tumors that typically have quite an extensive in situ component, but are quite bulky tumors and actually form a mass. If resected, they will have areas of invasion. So a question arises with respect to whether you put these in a question might arise whether you put these into an in situ category if you can't find any invasion. But as these are forming a mass, I typically include them in the T stage as than 2 centimeters or more than 2 centimeters, just like you would for other types of squamous cell carcinoma. This is an example of a basaloid squamous cell carcinoma, and I just wanted to draw a distinction between a basaloid squamous cell carcinoma and non-keratinizing squamous cell carcinoma, which is typically what one sees in the Pharynx, HPV related. A basaloid squamous cell carcinoma is by definition high grade. They're usually found in the hypopharynx. Sometimes also you'll see them in the esophagus, fairly common in the piriform sinuses. They have extensive comedonecrosis, basaloid pattern. They may have a peripheral palisade, and some they can contain a lot of extracellular matrix such that they look very adenoid cystic-like. Non-keratinizing squamous cell carcinomas are typically HPV-related or pharyngeal carcinomas, which tend to have a fairly good prognosis, occur in younger patients, non-smokers, non-drinkers, men more commonly than women. These tumors certainly have considerable overlap with basaloid squamous cell carcinoma. They'll often show focal keratinization. They're P16 positive, and they're really distinct types of tumor. This is a higher image of a basaloid squamous cell carcinoma showing the squamous differentiation that you can sometimes see in these tumors that allows you to recognize it. Often there will be overlying carcinoma in situ. In contrast, is an oropharyngeal HPV-related non-keratinizing squamous cell carcinoma. It's very strongly P16 positive. Tumors will often invade as sort of rounded nests. They may incite very little desmoplasia. They're quite cystic, and certainly they're very cystic in lymph nodes. And pathologists sometimes are quite uncomfortable with the diagnosis of invasion in these, but they're usually quite expansile and extend beneath the normal surface epithelium, so it's not typically all that much of a problem to diagnose them as being invasive. Carcinomas of the minor salivary glands. This is the list that they give. This is the WHO 2005 classification. It doesn't include some newer entities such as mammary analog secretory carcinoma. They recommend grading for some types of salivary gland carcinomas, including adenoid cystic, adenocarcinoma NOS, and mucoepidermoid carcinoma are all graded as low, intermediate, and high grades. Pleomorphic adenoma, or malignant mixed tumor, they're categorized as low and high grade. In experience, it's very unusual to have a low-grade carcinoma ex pleomorphic adenoma. They're really high-grade, either adenocarcinoma NOS or salivary duct carcinoma, and other types, even squamous cell carcinoma. And invasiveness is important. This is a lot easier to assess in salivary glands than in salivary glands, because the definition of invasion really is determined by whether or not the tumor extends beyond the capsule of the pre-existing pleomorphic adenoma. And the extent of that invasion, is it more than 1.5 centimeters or than 1.5 centimeters? But in fact, the vast majority of pleomorphic adenomas, the cavity are not encapsulated, so it's a challenge sometimes to really determine that invasiveness versus non-invasiveness category. A lot don't have to face it that often. Just talking about other types of cancer, adenocarcinoma non-salivary gland type, extremely uncommon in my experience in the oral cavity. You have to obviously rule out that you're not dealing with an adenosquamous carcinoma, which would be a much more common circumstance. And as I mentioned before, They have this category of a large cell carcinoma neuroendocrine type, or poorly differentiated neuroendocrine carcinoma, and other types of cancer, including mucosal melanoma. Other type cannot be determined. The WHO 2005 Head and Neck Edition just categorizes neuroendocrine carcinomas as typical carcinoid, atypical carcinoid, small cell neuroendocrine carcinoma, and small cell carcinoma, either with squamous or adenocarcinoma. Atypical carcinoids do occur. They usually happen in the larynx, usually in the supraglottis, but they're extremely rare. And also, uncommonly, we see large cell type neuroendocrine carcinomas that really don't fit for an atypical carcinoid. They have prominent necrosis. They don't have any of the organoid pattern of growth that you might see with a carcinoid tumor. They have a very high mitotic rate, and so they really don't fit from a behavior category into the moderately differentiated neuroendocrine carcinoma. So it's helpful that they've added this large cell category. Histologic grade, of course, is another component of the protocol, and in the system, I think it's fair to say that the outcome of squamous cell carcinoma doesn't really correlate very well with the grade that we give it. We use a fairly simple grading system, such that if I see a tumor that's a squamous tumor with some atypia, but having some trouble deciding whether or not it's actually a malignancy or some kind of pseudoepitheliomatous hyperplasia, then I'd call it well differentiated. And then the vast majority of keratinizing squamous cell carcinomas get lumped into a moderately differentiated category because they're obviously malignant. And there are other tumors you really have to look at them to recognize that they're squamous cell carcinomas. They're high-grade tumors, such as the one I've got here on the right-hand side, but difficult to see squamous differentiation, and you might have to resort to some immunohistochemistry to try to demonstrate that. And it's poorly differentiated. So what it means is that the bulk of cancers fall into the moderately differentiated category. Some tumors, of course, such as verrucous carcinoma and basal carcinoma and sarcomatoid variant to squamous cell, have some implied biological potential. Well, non-keratinizing squamous cell carcinoma of the oropharynx, so would grade those moderately or poorly differentiated, just depending on how much atypia you have. But I think many people now are recommending that you don't grade them because they really have, again, an implied biological potential, based on the fact that they are HPV-related cancers. Overall, they tend to behave better than conventional squamous cell carcinoma, than smoking, drinking-related carcinoma of the oropharynx. There's some indication, perhaps, that anaplasia or really marked atypia within those non-keratinizing carcinomas will imply worse prognosis. But I think it's probably a reasonable approach to not to grade them and just give them a category of HPV-related non-keratinizing carcinoma. What behind grades? The protocol says that you can either give the highest grade or the most prevalent grade. Give the most prevalent grade and then mention if a higher grade is present. This is just an example of this high-grade carcinoma or high-grade component of the squamous cell carcinoma extending through in a very aggressive-looking fashion between the skeletal muscle fibers and the tongue. And there have been re-proposed models to evaluate squamous cell carcinoma independent of the morphologic features, or the cytologic features, that is. And recently, there's a histologic risk model for oral squamous cell carcinoma, which includes the pattern of invasion, the presence or absence of perineural invasion, and the degree of lymphocytic host response. This may actually be a pretty good predictor of outcome in low-stage orals, especially those that are N0. Here's the next category, which is microscopic tumor extension. Again, I usually sort of combine that in the diagnosis with the macroscopic tumor extension. Effects. For all intents and purposes, neoadjuvant therapy is not used in head and neck cancers. It's not used routinely. We typically see treatment effects only in salvage surgeries, so patients who've had chemoradiation but then fail that and then have to undergo surgery. I don't include this as a component of my synoptic report. Next, get to margins. Margins can be assessed. Margins uninvolved by invasive carcinoma or margins involved by invasive carcinoma. If margin is uninvolved, you have to give a distance from the closest margin. And close in head and neck cancer is considered to be 5 millimeters or less. This margin categorization can be applied to all carcinomas, salivary gland carcinomas, and squamous cell carcinomas at the sites in these protocols. With melanoma, I think melanoma, it's a bit more unpredictable how the status is going to deter behavior of melanoma. There was a recent large study from MD Anderson, mucosal head and neck melanomas, that find a worse outcome, those with a positive margin of less than 1 millimeter, but that's not found to be statistically significant. Also asked to give the margin status with respect to carcinoma in situ, and for the head and neck specimens, of course, this just applies to squamous cell carcinoma and its variants, but the margin status for a mucosal disease applies to moderate dysplasia and up. And then you have to give the distance from the closest margin, by that distance, and by the site of the closest margin. I say if it's more than 5 millimeters, I typically report more than 5 millimeters rather than measuring distances to quite distant margins. The protocol discusses quite extensively the issue of keratinizing versus non-keratinizing dysplasia, the upper airway, and this is kind of a controversial topic. And it creates ultra-observer variability, I think, in the grading of dysplasia in the upper airway. But typically in the oral cavity and elsewhere in the upper air digestive tract, we see keratinizing dysplasia. Not to say that we don't see non-keratinizing dysplasia. We certainly do see it, especially in the floor of the mouth and on the undersurface of the tongue. Carcinoma in situ, true bill, carcinoma in situ, and often those are described as being erythroplakic or red lesions rather than leukoplakic or white lesions. But true carcinoma in situ is actually quite uncommon in keratinizing dysplasia. And so the terms severe dysplasia and carcinoma in situ are used synonymously in the upper air digestive tract. And clinicians may not appreciate this, and they may see some distinction between severe dysplasia and carcinoma in situ, but really they're used synonymously. And in fact, it turns out that dysplasia and above, all those types of dysplasia really have a similar risk of progression to invasion, and some have proposed that we introduce a binary system of reporting dysplasia in the upper airway, where you have mild dysplasia or low grade versus high grade, which is everything else, moderate and above. But that hasn't been adopted by the WHO. Have to beware, because in the oral cavity, it's not all that uncommon to have invasive carcinoma that arises from a surface epithelium, really just looks mildly dysplastic. is an example here, just for illustration purposes, of the mouth carcinoma in situ. In fact, this is a true keratinizing carcinoma in situ. It's showing full thickness abnormalities, maybe not down here, but certainly up here and here. But it's an atypical parakeratosis that you have on the surface. It's an example of one of those invasive carcinomas that just seems to arise out of nowhere. This was a part of a glossectomy specimen that I got for a patient who had a sizable verruca carcinoma of the lung, and in the adjacent mucosa there was an invasive squamous cell carcinoma with really very little abnormality of the surface epithelium above it. And with this epithelium, you can see this invaginating, fairly bland epithelium just merging directly with these very atypical cells dropping off the bottom and invading into the underlying stroma. This is another area. You can see that sort of pallor of the epithelium over here on the left, which is similar to the pallor of the epithelium in these invasive islands. But I think you'd be hard-pressed to sort of call this surface here, if you had just a biopsy of that, as anything worse than mild dysplasia. You do get funny things in the oral cavity. Sometimes these are some photomicrographs of a rare case of patoid carcinoma in situ of the oral cavity. This patient was a woman in her mid-40s who smoked and drank very heavily. She had an invasive squamous cell carcinoma, and then adjacent to that invasive squamous cell carcinoma, she had the pagetoid type situ disease. In fact, these cells spread along the ducts of minor salivary glands, and you got this sort of colonization or canalization of the lobules of the minor salivary glands. Is a very unusual case. The next component, lymph-vascular invasion. There's no distinction here in the AJC categorization of the size of the vessels, so it's really all just called lymph-vascular invasion. Perineal invasion is very common, especially in the tongue. Perineal invasion has a decreased of local regional control, decreased survival, and is indicative of a higher risk of lymph node metastases. The relevance to the nerve site and cells that are involved. No definite indication that nerve diameter or the involvement of nerves of a greater than 1 millimeter, for instance, has a prognostic relevance, but it is included, for instance, in the histologic risk model that I just discussed a few minutes ago. And there's some evidence that extratumoral perineural invasion does have more relevance than with poor prognosis than intratumoral perineural invasion. Extranodal extension is another element that needs to be included. It's funny, it's discussed in the staging section under extracapsular extension. I think I prefer extranodal. Example of venous invasion, just for illustrative purposes. Sometimes it can be very hard to recognize, and elastic stains can be helpful to demonstrate that. And I think it's important to mention this large vessel invasion when you do see it, because it may be important, for instance, for this patient to have a CT scan of their chest just to make sure he or she does not have metastasis to the lungs. Here's an example of peri or intraneural invasion, peri and intraneural invasion in the inferior alveolar nerve of the mandible. Sometimes, actually, when you have a very large nerve involved, it's to just make sure that when you see tumor adjacent to fairly large nerve fascicles, they're not undercalling perineural invasion, because what you'll be actually seeing is intraneural invasion within a large nerve. I'll just do that. Okay, now we come to the pathological staging. This applies to all carcinomas, excluding malignant melanoma. You know, the clinical and imaging correlation is really essential with these cases, and that's why we have tumor boards and discuss these cases. With respect to oral cancer, P1 is a tumor that's 2 centimeters or less, P2 between 2 and 4 centimeters, PT more than 4 centimeters, and then 2 categories of PT4, 4A, which is moderately advanced, and T4B, which is very advanced local disease. One issue that sometimes arises is with respect to the assessment of bone. So you have a PT3 tumor where there's minimal erosion of cortical bone by tumor, but more than that really should be considered PT4. Something that can be difficult to assess in patients who have no teeth. They have quite excessive recession of the mandible, and the tumors will kind of erode. If it's an alveolar tumor, it will erode directly down onto that bone, and sometimes you will actually see excessive erosion of the bone, the leading edge of the tumor, and in fact the tumor itself might be separated from the leading edge of the tumor, so that you don't actually see tumor in the medullary space of the bone. But I would still consider those PT4 tumors, and the clinicians do as well. Renal lymph node metastases for most of the neck cancer sites, with the exception of nasopharyngeal carcinoma. This is the staging for the regional lymph nodes. It's important to submit all the nodes in toto. With those that have gross involvement, then I submit 1 per centimeter, and I concentrate on potential sites of extranodal spread. Sometimes you'll get post-irradiation neck dissections with a residual mass, and it may be of relevance in those cases to submit more of an enlarged node. Neck sections. I'm not going into the terminology very much of neck dissections, but it's important to know the levels in the neck, and it's important that they're properly labeled by the surgeons in order to accurately give the indication as to which lymph nodes are involved. It's very uncommon now to have a true radical neck dissection. So radical neck dissection includes a cervical lymph node dissection, which is levels 1 through 5, possibly level 6, mandibular gland, the tail of the parotid, of the sternocleidomastoid muscle, omohyoid, internal jugular vein, and cervical plexus and spinal accessory nerves. We rarely would receive that. We typically would receive either a modified radical neck dissection, which spares one or more of those elements, or more commonly, a selective neck dissection. So, for instance, in laryngeal carcinomas, we'll typically get a level 2 through 4, or what's called a lateral neck dissection. For the oral cavity or lip, we make a supraomohyoid neck dissection, levels 1, 2, and 3, or sometimes levels 1, 2, 3, and 4. The neck dissections for oral cavity and lip cancers can be either unilateral or bilateral, just depending on the relationship of the tumor to midline. So with respect to neck dissections, you have to give the number of lymph nodes examined. And if you can't give a number, you have to explain why you can't do it. The number of nodes, it's sort of difficult to know if they're not grossly identified. I tend not to increase the number of nodes from the gross description, but sometimes I will reduce it because things will be submitted as nodes which are not nodes, like little pieces of vessel or pieces of fat or fibrous tissue. Within the lymph node category, the number of lymph nodes involved, optional element is to give size or greatest dimension of the largest metastatic focus in the lymph node. And I do provide that. But typically what I'll provide, and this has been changed from the previous one where you had to give the size of the node itself. So I will quickly give the size of the greatest metastatic focus and the size of that node. So a 4 centimeter metastatic deposit in a 2 centimeter lymph node, for instance. The next section is with respect to extracapsular extension, and that's a new component as well. So whether or not you identify extracapsular extension, and if it is present, whether you can provide the distance from the lymph node capsule. Difficult to determine in some cases. Sometimes you have lymph nodes which really don't have a defined capsule, and so determination of extracapsular extension is sometimes problematic. With respect to the size of these metastatic foci and lymph nodes, the protocol mentions that the size of the metastatic focus, or the size of the node, as given, for instance, in the end stage, is really questionable with respect to the prognosis. So, hence the change to the size of the metastatic focus itself. I'll mention that the category of isolated tumor cells has been removed. So, isolated tumor cells are single cells or cell clusters not more than 0.2 millimeters, and in other sites they are often reported as N0. But the mentions that evidence for the validity of this practice in head and neck squamous cell carcinoma and other histologic subtypes is lacking. So report it. Just with respect to extracapsular or extranodal extension, this is an indication for concurrent chemoradiation. So it's the addition of chemotherapy to radiation. So I think it's important in these circumstances to be somewhat conservative. And in speaking with clinicians, I think extranodal extension really means something a little bit different to clinicians and radiologists than it does to pathologists. So logically, nodes with extranodal extension have spiculated borders and irregular borders. Clinically, they might be matted nodes or immobile nodes. Obviously, we can see something much more subtle, that is microscopic extracapsular extension. There is no standard definition for what constitutes extracapsular extension. I think that as tumor that's beyond the node capsule into the soft tissue without a desmoplastic reaction. Sometimes you have an issue when you have nodes without a complete capsule. The stance that I'm showing here, it's pretty clear-cut that you have extranodal extension into surrounding fat. Hence, we have a node with intranodal tumor, and you see the subcapsular sinus kind of disappears, and you have some thinning of the capsule and desmoplasia in the surrounding tissues. And here you've got, on higher power, some nests of tumor just the nest. I think we would count this as focal extranodal extension, but whether or not it merits chemotherapy, I'm not too sure. So Lewis et al. Published a paper in Modern Pathology in 2011 where they graded extranodal extension in oropharyngeal cancers which had been treated surgically. Grades 1, 2, 3, and 4, depending on the extent of extranodal extension, with grade 4 being no residual nodal tissue or architecture. Verse 3, which was clearly a node, but with more than 1 millimeter of extranodal extension. And they found that the recurrence rate was much higher for the grade 4s versus the grade 0 to 3. So 3 of 64 recurred among the grade 0 to 3 group. And 4 group did have a statistically significant worse survival, but wasn't independent of the T stage, so the relevance is still a little bit unclear. Okay, next, distant metastases. Of the AJCC staging manual, pathological M0 is an undefined concept. So pathologists cannot provide a P1 M1 stage unless it's documented in a biopsy specimen or autopsy. Just thing good to know. Staging for mucosal melanoma is a little bit different. Digestive tract melanomas typically occur in the nasal cavity, about 2/3 of them. A quarter occur in the oral cavity. They tend to be aggressive, even when they're very small, which is why they developed this basically a PT3 and up staging system. So a PT3 tumor is a mucosal-based tumor, whereas a PT4 tumor is either moderately advanced or very advanced disease. They exclude pure in situ melanomas, which are extremely rare. Sometimes we do see in situ melanoma around an invasive melanoma of the nose, but a pure in situ carcinoma I think would be extremely rare. And this system for staging the mucosal melanomas applies to the larynx, nasal cavity, and paranasal sinuses as well. Additional pathological findings. I will report dysplasia. They have these as optional categories. I will report dysplasia. I'm not sure I always divide it into keratinizing versus non-keratinizing. I think it's important to report certain things, like inflammation is sometimes relevant. For instance, if you're carcinoma arising in chronic graft versus host disease. Epithelial hyperplasia is relevant in some circumstances. So, for instance, you might have carcinoma that's arising in a background of proliferative verrucous leukoplakia, and you're able to tell that based on prior biopsy specimens. Ancillary studies that include P16 in the oropharynx, for nasopharyngeal carcinomas, FISH for salivary gland tumors. I'll be talking about that in a few minutes. I don't have that much time left. In fact, I'm running out of time. Comments, I them liberally. Okay, so I'll talk now about some of the highlights from the other sites. So in the pharynx, what's new? They've divided conventional squamous cell carcinoma into keratinizing and non-keratinizing types, obviously to emphasize the HPV-related non-keratinizing carcinomas. With the nasopharynx, they've finally done away with the numbering system, which is the old WHO numbering system. In fact, was last included in the WHO system in 1979. So I think it's about time that it was dispensed with. And in the pharynx is that HPV testing is a requirement for pharynx cancer. And EBV testing is a required element for nasopharynx cancer. EBV is found in virtually 100% of non-keratinizing nasopharyngeal carcinomas. Just another example of an oropharyngeal non-keratinizing squamous cell carcinoma. Again, these will often have a normal surface. They will typically rise in the crypts, but not always. So sometimes you may see carcinoma in situ on the surface, and sometimes they actually have a papillary or an exophytic component on the surface. And these tumors can be quite heterogeneous. They can look quite basaloid, but sometimes the cells are rather spindly. They'll very often have keratinization, but it's usually limited to less than 10% of the tumor surface area. We do on occasion see glandular differentiation. This is actually an example of an oropharyngeal adenosquamous carcinoma where you can see glandular differentiation in the upper left-hand side. Here you can see it at a little higher power. You can actually see there's clearly mucin being produced within these glands or with cells. carcinoma of the nasopharynx, eugenal keratinizing squamous cell carcinoma, non-keratinizing carcinoma, differentiated and undifferentiated types. This is also called lymphoepithelioma. These are sometimes difficult to separate and sometimes combined. And it really doesn't matter in terms of prognosis or treatment, and in fact, they're essentially all EBV positive. Basal squamous cell carcinoma is a new category of nasopharyngeal carcinoma added in 2005 to the WHO. This type of tumor is extremely uncommon. I think I've seen one of them as part of an undifferentiated carcinoma. It was, in fact, EBV positive, but they're extremely uncommon. A few highlights then. The end stage for nasopharyngeal carcinoma is different. And this is it right here. We don't usually get lymph nodes for a nasopharyngeal carcinoma unless they're just biopsied in order for a diagnosis. So it's not typically of relevance to pathologists too much. Okay, what is important is the ancillary studies. So some of HPV testing is required for oropharynx carcinomas, and EBV testing is required for nasopharyngeal carcinomas. So there's really no consensus as to the best methodology for HPV testing in oropharyngeal carcinoma. Typically, people use a combination of P16, tissue hybridization, and PCR for HPV DNA. But I think it's fair to say that P16 is a used surrogate marker for HPV status in non-keratinizing squamous cell carcinoma of the oropharynx, not necessarily head and neck squamous carcinoma in general. Actually, the cutoff that we use is greater than 70%, strong or strong, depending on who you talk to, diffuse nuclear and cytoplasmic staining. And really any other results would require confirmation. And recently, we started using P16 on neck FNAs. Very useful thing to do when you have a cystic or solid even neck mass in an adult patient for a primary site. Here's the suggested algorithm for oropharyngeal carcinomas. For non-keratinizing carcinomas, either completely or predominantly non-keratinizing, have strong and diffuse cytoplasmic and nuclear staining in more than 70% of the cells. That's HPV-related non-keratinizing carcinoma, and you don't need to do any confirmatory testing. If it's negative or focally positive and it's not keratinizing, you should do confirmatory testing. Now, for keratinizing squamous cell carcinomas of the oropharynx, you would also do the P16. If negative, you don't need to go further. But if P16 positive and it's keratinizing, then you should get a confirmatory test. And I think this jives with thing that's done mostly across North America. There was a survey of of HPV testing practices across North America sent out by the pathologists at Washington University, and they found that nearly half of the sites were using P16 alone. Sites were routinely using P16 in combination with in situ hydration or usually rather than PCR. The commonest cutoff was the 70% with strong cytoplasmic and nuclear staining. Okay, nasal cavity and paranasal sinuses. The carcinomas list is slightly different from those in the oral cavity. It includes the keratinizing and non-keratinizing types, the latter being historically called transitional or cylindrical cell. It includes SNUC and includes adenocarcinomas, both of intestinal and non-intestinal type. Most of the cancers arise in the maxillary sinus. There is some evidence that nasal non-keratinizing squamous cell carcinomas can be HPV related. And recently, some pathologists in Johns Hopkins described something called an HPV-related adenoid cystic-like carcinoma of the nasal cavity, which I have an example of, but I won't show in the interests of time. There. Just heard about inverted papillomas. In papillomas do imply greater risk for development of squamous cell carcinoma. You can see one right here. This is an inverted papilloma. Here's the malignant component of it. That's a lot less common than we might think, given the number of inverted papillomas that I see. I see very, very few squamous cell carcinomas that are rising in them. Or maybe I'm just seeing a bias of stage squamous cell carcinomas where the inverted component is no longer visible. With respect to larynx cancers, institution transoral laser excisions are very common for low-stage larynx cancers, and they're actually replacing radiation therapy for many of them. And this typically involves a tumor splitting procedure, as I mentioned before, where you have an anterior partial laryngectomy, a posterior partial laryngectomy, and a bunch of margins around the outside. It does create issues with respect to interpretation of the margins due to cautery artifact and the distance from margins. But the margin adequacy in glottic larynx carcinomas is thought to be a little bit less than in other head and neck sites. When you get to the staging, the correct PT stage assignment may require clinical information, specifically about the status of the vocal cord mobility or vocal cord fixation. So just depending on the that you're dealing with, most of the time if we get a laryngectomy, we're dealing with at least PT3 tumor. But the true staging does require information about the vocal cord mobility. A word about thyroid cartilage involvement. It changes the stage from a PT3 to a PT4, but the distinction is a little bit blurry. So in a PT3, says that you can have minor thyroid cartilage erosion, for example, of the inner cortex. There is a moderately advanced tumor. The tumor invades through the outer cortex of the thyroid cartilage. So what do you do about cases that don't have minor thyroid cartilage erosion, but not through the outer cortex? I typically call those PT4 tumors. The salivary glands, they have expanded the list somewhat and modified it slightly and dated it with new entities. So, for instance, they've added MASC, which is mammary analog secretory carcinoma, and they added cribriform adenocarcinoma of the minor salivary gland as a type of polypus low-grade adenocarcinoma. It's unusual that they've decided to add cribriform adenocarcinoma of minor salivary glands to the major salivary gland protocol, but they didn't add to the oral cavity protocol. It's important when you're dealing with major salivary gland tumors, just as an aside, to always keep in mind the possibility of metastases, either from squamous cell carcinomas of the scalp or face, or actually from melanomas. I see this all the time, especially in older patients in their late 60s, 70s, and above. Most of the time, I would say, when we have a spotted tumor, it's a metastasis, not the other glands, of course. So, the other thing that's very important about the major salivary glands is the ancillary techniques might include the use of FISH or PCR for the detection of fusion transcripts. For instance, in mucoepidermoid carcinoma, there is characteristically in the majority of cases a MECT1 MAML2 translocation. In MAC, you have a characteristic translocation called ET6 and ERK3, and another one in adenoid cystic carcinoma. With respect to the tumor staging, the PT staging in major salivary gland tumors, the tumor staging is done on the basis of size. So a T1 tumor is a tumor that's 2 centimeters or less with extraparenchymal extension. PT2 is 2 to 4 centimeters without extraparenchymal extension. And extraparenchymal extension upgrades it to a PT3. So it's important to recognize that extraparenchymal extension must be clinical or macroscopic. It can't be microscopic. Sometimes get into problems, I think, when you have kind of suboptimal grossing and you have a tumor that really should have been recognized as extraparenchymal extension grossly, but it wasn't. And in those circumstances, you can go back to the gross specimen, or it's been completely submitted and it seems to obviously be with outside the gland. I would call those PT3 tumors. Just as a final word, I would just show you a couple of pictures of a mammary analog secretory carcinoma. This, I think, is one of those salivary gland tumors where many people would put it on their microscope and go, well, geez, what the hell is this? It doesn't really look like anything characteristic. So kind of what the hell is this? Salivary gland tumors typically used to turn out to be sphenic cell carcinoma, some adeno-NOS. Now a considerable number of them are actually masks, and do bear some resemblance to a sphenic cell carcinoma, depending on the case. They often have a lot of this slightly eosinophilic cytoplasm, nuclei that are fairly bland, sometimes with very prominent nuclei, and cellular mucin production, slightly vacuolated or microcystic appearance. And these tumors are classically very strongly positive for S100, as are for CK19 and CK7, hemoglobin if you have it, and will stain with GCDFP. I'm still a bit uncomfortable with these tumors. We've had 5 or 6 of them here over the years. I send them out to get fish to identify the characteristic translocation. That concludes my part of the talk, and I'd be happy to answer any questions that you might have.
Hi, this is Dana Wilson-Lee from CCO. If anybody has any questions that they would like to pose, please direct them to Pathology Initiative, and I will pass them on to Dr. Bullock. No questions? Not muted. Okay. No questions.
Yeah. I find this particular checklist learned because of the extent of it, where it covers several anatomic sites and minor salivary gland. Complicated one when trying to fill out. So I certainly appreciate your approach and your actions for going over the head and neck synoptic. Do you have any experience with using the ECC checklist filled out from the CAP?
No, we haven't. In Nova Scotia, we have cooperated with CPAC and have been provided with funding to introduce the true electronic synoptic reporting with the ECC checklist, but hasn't been introduced yet, and some time before it is. There's a lot of issues with respect to the various lab information systems that we have, and the cost of maintaining the checklists. We're just simply purchasing them. So it hasn't been introduced yet, but I think it will be in the next year or so, probably concentrating initially on the major types of cancer: prostate, breast, lung. So I haven't used the electronic checklists. We're seeing synoptic-like reporting, I guess.
Okay, I have a question from Dr. Bacani from the University of Alberta Hospital in Edmonton. His question
Okay.
is, how often do you have HPV testing accordant with P16 IHC results? We do P16 testing and concerned whether we should do HPV testing.
I think it's very rare. It's common in my experience to have a non-keratinizing oropharyngeal carcinoma that is P16 negative or even weak, that is less than the 70% cutoff point, almost indeed strongly positive. So it's rare that we have to resort to confirmatory tests. And we have those tests available in-house, so we have to send the cases out anyway, either for in situ hybridization or for PR.
No other questions? No.
All right. Okay. Thank you very much for the presentation. On behalf of Cancer Care Ontario, the partnership.
Partnership.
Yeah, sorry, the Canadian Partnership Against Cancer and Canadian Association of Pathologists. I would like to thank Dr. Bullock for a truly comprehensive, informative, and a very clear presentation. This is the second session of the 2014 series of CAP checklist presentations, and we welcome your comments and suggestions for ways to ensure these sessions are informative and relevant to your practice. Please include your feedback and suggestions as part of your completed online evaluation. Once the recording for this presentation becomes available, it will be made available for wide distribution via links posted by Cancer Care Ontario, CPAC, and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. As a reminder, both the live and recorded presentations are eligible for continuing education credits. And see the session notes for more information. The CE certificates for the checklist sessions will only be issued for 1 month from the presentation date. The session will remain electronically for an undetermined period of time, but CME certificates will only be issued for that 1 month. Just a reminder of the upcoming sessions for 2014. We have the next session occurring next week, February 27th, Dr. Tumor. It will be a special session where we specifically talk about for re-excisions, revising, where checklists should be used, and how to use the checklist in usual circumstances. So I hope to see a good turnout for that session, and thanks to everybody for attending, and again, thank you very much to Dr. Bullock.